first issue that I'd like to talk about is what role has my organization played in terms of promoting collaboration between public health and Medicaid. And when I talk about public health, I'm really going to focus on mental health. When I worked for the state of Maryland for a number of years, we worked with Medicaid and with the uninsured in order to make sure that there were mental health services. So in 1997, Maryland moved to Medicaid. However, there was a carve-out for mental health. Medicaid, individuals with Medicaid, individuals who were uninsured, received services through the public system in a fee-for-service system. But it was a carve-out from the Medicaid managed care company. So that was one experience that I had, and that during that time we had to work with Medicaid, and we had to find a way to make the system work. It was unusual for us because previously we'd only worked with the uninsured and we didn't know much about Medicaid. So we had to deal with the Medicaid rules, working with people who were accustomed to working with the insurance side of Medicaid, and trying to get people to understand the culture of mental health. In my current role as the director of NASHBID, what we've seen over the last 10 years is an integration of mental health and substance abuse, and the integration of Medicaid into behavioral health, or behavioral health into Medicaid. So there have been a number of states that have moved ahead and they're already integrated, and then a number of states that are beginning the integration. What we found is that there is a cultural difference between the Medicaid system and people who work in the Medicaid system and people who work in behavioral health, mental health, and substance abuse. And that's primarily because the people who have worked in the behavioral health side, mental health and substance abuse, they've come from the side of providing services for people who may just need traditional services, inpatient and outpatient. But they've also worked with people who need a full continuum of care and may need services like housing, employment, rehabilitation that aren't within the usual Medicaid system. So they work on both population health and safety net services, whereas the people that have traditionally worked just on the Medicaid side haven't been involved with that safety net function. So we've found that what works best in the states is for Medicaid, individuals who work on the Medicaid side, individuals who work in mental health, individuals who work on the substance abuse side, to spend a certain amount of time understanding each other's system. What we've seen is that people want to do a good job. Whether they work for Medicaid or they work in behavioral health, they want to do the right thing. It's just trying to deal with the system that they've been accustomed to, and then trying to translate that into the system that they want to become. And it takes people who can articulate the culture, can articulate the differences, can articulate the goals, and get people to agree on how to proceed and how to respect each other. I would say that the challenges to the collaboration really come from the fact that many of us are best dealing with what we've become accustomed to, and change ends up being very difficult. So if I'm from the Medicaid system, I've learned rules and learned how to follow those rules and learned how to set up waivers, but it's following a traditional system, whereas on the behavioral health side, you're often looking at how do I get the needed services for this individual that may not fit anybody's rules. It may be a matter of trying to think outside of the box and trying to find ways to meet the needs of this one individual. And it may only be that one individual when you're talking about case management and the special needs of that individual. So trying to get people on both sides to understand the importance of doing both and to move away from your comfort level that's established by repetition and following the same pattern over and over again, and being able to deal with that change that's uncomfortable. In terms of lessons learned that I think my colleagues could benefit from, many of the states are at different levels of integration, and in Maryland we had worked through the integration, I think in a very successful way. The people in Medicaid were excellent to work with, the people in behavioral health were very good to work with, people in public health were very good to work with, but all these good people often would get together and not understand each other. And that's not unusual. So it's trying to get people to be able to respect each other, respect the differences, and not come away from the meeting thinking how terrible the other people are, but being able to respect that difference and be able to work on it for the sake of the consumer and making sure that the consumers are the ones that are going to benefit from the system, and not to get caught up in our own issues. Also, our federal partners over the years were very helpful. When we look at SAMHSA and we look at CMS, they were very helpful in terms of setting up technical assistance, setting up webinars, trying to educate us. And what ASTO is doing now, I think, is very helpful because they're trying to get people to talk to each other, trying to identify those problems, and we'll be able to take what ASTO has learned to our states and help them to be able to integrate more successfully. Because we only see this moving forward: increased integration, increased Medicaid, increased managed care. And the more ASTO is successful with their project, the more it will help us as we move forward.